So based on Mr. Jones' current presentation, my first PT intervention session would include functional bed mobility progression, including rolling, supine to sitting on the edge of the bed, as well as getting him to increase tolerance to upright sitting at the edge of the bed. I chose this intervention because he's now hemodynamically stable. His ventilator settings remain at a good point to do early mobilization. His RASS score is now at 0, which indicates full alertness, making him appropriate for activity participation. And then one thing to note is that it is his first treatment session. He does have ICU acquired weakness. He has had impaired upright tolerance and aerobic deconditioning, as well as that bilateral plantar flexion tightness. So I think starting off at lower level would be the best for this patient, and then just progressing as tolerated. For intensity, I would keep the intervention at a low to moderate intensity, because this is recommended for the ICU and especially for a patient as deconditioned as this, with targeting the Borg scale, Borg RPE scale of 3 to 5 out of 10. And then I would also closely monitor him for his physiological response. I would begin with rolling and supine to sit with assistance as needed, followed by supported sitting at the edge of the bed with an overall goal of sitting at that edge of the bed for 3 to 5 minutes, depending on his tolerance level. This intensity is appropriate because the intervention should be individualized to the patient and response driven, and based off of his last finding of having an issue with prolonged upright sitting position, we want to start here and progress as he's able to. If he tolerates the intervention well, I could progress it by first increasing the sitting duration, or I could do it by decreasing physical assistance with the bed mobility part. Other areas that I could progress is by adding dynamic sitting tasks like reaching in sitting, doing unsupported sitting, sit to stand training, or like moving on to like transfers. If he doesn't tolerate it well, I could regress it by reducing the sitting duration, or by giving him more assistance with the bed mobility part, or even raising the head of the bed and having him just kind of adapt to the upright positioning. I could also regress this by just going back to the bed and doing either active assistive or active exercises in the bed, because this would require less of him. During the treatment, I would continuously monitor his heart rate, blood pressure, mean arterial pressure, oxygen saturation, respiratory rate, his fatigue levels, and his overall appearance. And signs that he isn't tolerating it well, and we might need to terminate or pause, is if he has a significant increase or decrease in blood pressure, his oxygen begins to lower below 90% or so, 88 or 90%. If his respiratory rate becomes excessive, like greater than 35 breaths per minute, or if he has dizziness or syncope, if he's unable to follow commands, or if he becomes excessively fatigued.